Pleasure and honor. Let me start recording it before I. Oh, Delia has already started recording, I think.
Sure.
Okay, we started recording. Yeah, it's my great pleasure and honor to introduce one of my mentors, Dr. Daly Davis, who is going to be presenting the grand rounds this morning. And I had to read his bio because it's quite extensive, but I had cut down to manageable level. Dr. Davis is interim chancellor for the University of Nebraska Medical Center, specially trained in pediatric infectious diseases at the Hospital for Sick Children in Toronto, Canada. Dr. Davis currently consults in infectious diseases at Children's Nebraska. He's a member of National Biodefense Science Board Advisory to Assistant Secretary for Preparedness and Response, which is the chair of Readiness and Resilience Working Group, and the AAP Council on Children and Disasters Board. Dr. Davis previously served on the Board of Scientific Counselors for the National Centers for Infectious Diseases, Centers for Disease Control and Prevention, and the Red Book Committee on Infectious Diseases. He has over 230 peer-reviewed publications. Dr. Davis received his MD from the University of Toronto in Canada and holds master's degree in community health from University of Toronto, as well as the degree in healthcare management from the Harvard School of Public Health. On my personal note, when Dr. Davies was chair of pediatrics at Michigan State University, he initiated or organized annual research day, research conferences for all the departments of pediatric across the state of Michigan. And he asked me to be a co-chair of this organizing committee. And I learned from this master how to successfully organize conferences. So Dr. Davis, thank you all, everything you have done for me, for mentoring me, and thank you for accepting our invitation. The floor is yours.
Thank you so much, Deepak. Great to see you again. And I thoroughly enjoyed the time that we shared together, the 10 years when I was in Michigan. And thank you for inviting me to do this presentation. So welcome to all the members of your department, students, faculty, and staff. So the topic I'm going to talk about today is flesh-eating disease. And, you can see from the title there, it's Is It All But Gone? Okay, now we're not advancing anymore. So what am I doing here? Okay. I have no conflicts of interest. Okay, here we go. So I'm going to use a case presentation to illustrate the typical presentation of what is known as flesh-eating disease, which is actually necrotizing fasciitis. I'm going to give you a bit of historical context, give you some case definitions for the broad category of infections that I'm going to be mostly talking about, which is invasive group A streptococcal infections. And then I'm going to talk about the clinical contexts, and then epidemiology and outcomes. And then we're going to talk a little bit, very little because of the time, on vaccine efforts. So this is a patient I saw several years ago. So she, on day one of her illness, 16-and-a-half-year-old girl, developed chickenpox, was seen by her family doctor on the second day and given a cyclovir. And then she developed dysuria, labral swelling, redness, and tenderness extending to her abdomen and her right leg. And she was taken to Alberta Children's Hospital Emergency Department, where I was working at the time. So when she was observed, she looked unwell. Her temperature was elevated, heart rate was up, blood pressure was on the low end. And then she had crusted chickenpox lesions across her scalp, trunk, limbs, and groin. And she had, her groin was very, very indurated and very, very tender. Her cardiorespiratory and abdominal exam was otherwise remarkable. Now, this picture you're seeing here was a few days later, after she'd had some debridement of that area. Her white count was on the low end. Her hemoglobin, platelets are shown there. PT, PTT, CPK was elevated, as you can see. Her liver enzymes were normal. So she was started with intravenous penicillin and clindamycin. And she also got high-dose immunoglobulin. And then she went on to have surgical debridement. And the histology showed necrotizing fasciitis with a lot of gram-positive organisms in chains, which ultimately grew group A strep, group A beta hemolytic strep. And the culture grew group A beta group A beta hemolytic strep, and some Staph aureus. And because of the staph, cloxacillin was added to the regimen, pending the susceptibility. She ended up getting 3 weeks of antibiotics. She needed a split thickness grafting of her wound. She had what I would call a good recovery, but I use that word carefully because this is what happened. You can see that she still was left with a significant scar. So I got interested in this condition when I was actually doing my training in Toronto as a fellow. And this was the Toronto Star, which is the major newspaper in Toronto, talking about MDs on alert for dangerous trap infection. And then as I moved to Calgary, there was another story of a flesh-eating disease takes boys. So it was a major headline in the um, early 90s and in the early 2000s. And here's another headline. And I'll show you that this is not really unique to those eras. I'll show you some other um, contemporaneous headlines as well. This is the most interesting story to me that I saw. This is called the Weekly News, World News. I'm not sure this newspaper exists anymore, but it says flesh-eating virus invades the US. Flesh-eating virus. And then it goes on to talk about the untold story of the biggest medical cover-up since the AIDS epidemic. And of course, it says fear that 50 million could die from mystery bacteria that kills in minutes. And of course, the change from virus to bacteria in the same article. So meanwhile, this story in the Calgary Herald talked about this infection being extremely rare. And so the question is, who's actually right? So, I'm originally African from Nigeria. And so this is the eyes of the hippopotamus. For some of you might know, this is the African equivalent of the tip of the iceberg. So the question is this the tip of the iceberg? Which, of course, the hippo, when it comes out of the water, is much bigger than its eyes. Or is it much ado about nothing, as Shakespeare would say? So let's just dig down into some of these definitions. So what is flesh-eating disease? Well, flesh-eating disease is necrotizing fasciitis. It's a deep-seated infection of the subcutaneous tissues that results in progressive destruction of fascia and fat. There are three main kinds: mixed aerobic, anaerobic, and then group A strep is probably the most common, and then clostridial. Now, there are other organisms that can also lead to necrotizing fasciitis, but these are the three most common. And one of the key take-home messages for you today is that it may or may not involve the muscle, because this is an infection of the fascia, fat, and fascial coverings, as well as the muscle. So you should check the CPK, but it's important to know that if the CPK is normal, it does not mean that they don't have necrotizing fasciitis. So this is a newborn with really a very severe case of necrotizing fasciitis. Now, if we go back in history and look at Hippocrates in the 5th century, Hippocrates actually may have described this condition. So here's a quote from him. The erysipelas would quickly spread widely in all directions. Flesh, sinews, and bones fell away in large quantities. Fever was sometimes present and sometimes absent. There were many deaths. The cause of the disease was the same to whatever part of the body it spread. So probably not a new disease. But in terms of recent history, um, I just want to give you a bit of historical context. In 1978, uh, Todd et al. In the Lancet published this new condition they called toxic shock syndrome, which was associated with phage 1 staphylococci. And this particular description described 7 children who basically had fever, headache, confusion, conjunctival hyperemia, a rash, diarrhea, and then they went into DIC. One of these patients died, and in this particular patient, they identified a phage group 1 Staph aureus, STSS1, and basically they described this what we now know as toxic shock syndrome. Um, and then, it's basically in 1987, Kona et al. Actually described a toxic shock-like syndrome, which was very similar to what Todd had described. But this time around, instead of being caused by staph, it was caused by strep. And they called this a staph TSS-like syndrome. So in terms of the modern descriptions of STSS, the first description of STSS in real depth was by Dennis Stevens in 1989. And he basically identified 20 young, healthy people who were from the Rocky Mountain area who had features that to all intents and purposes looked like staph toxic shock, with one distinction that they had this necrotizing fasciitis. Some of them had necrotizing fasciitis. And about just over half of them, which was not something that was really described with staph toxic shock syndrome. And he was intrigued by the fact that these were young, healthy people. The average age was in the 30s, and 19 had shock, and there was a 30% case fatality rate, and they all had group A strep identified from a normally sterile site. So in this description then, he identified this toxic shock syndrome that was very similar to staph toxic shock, but he found a toxin that was very similar to the STSS1, which is a scarlet fever toxin A, he called it. And as you can see, these are the findings that he identified. So there was a working group in 1993 that came together to say, let's talk more about what is this streptococcal toxic shock and what is the case definition. And so this is the case definition that was derived. So in order to have somebody being identified as having severe group A strep infection, you can either have invasive disease, which is isolation of group A strep from a normally sterile site, and then there's a condition known as streptococcal toxic shock, and then necrotizing fasciitis. So STSS, which is streptococcal toxic shock syndrome, was now further defined as having isolation of group A strep from a normally sterile site, which will be considered confirmed if they meet all the other criteria, or from a non-sterile site, which will be considered probable if they meet all the other criteria. But in addition to the first criterion, they also had to have hypotension, which is blood pressure less than the 5th percentile for their age, and 2 or more organ systems. And so one of the key things here is that a lot of these organ systems are very similar to what you would see with staph toxic shock, with the big difference being that this soft tissue necrosis or necrotizing fasciitis, myositis, or gangrene was also a big part of it. So that was the key. And so one of the questions that I had when I was interested in this condition was, we noticed that Dennis Stevens was describing young, healthy adults as having toxic shock syndrome. So with funding from the CDC, we actually did a population-based surveillance study in the province of Ontario. And what we identified over a 2-year period were 323 cases over a population of 11 million people, which accounted for about 1.5 to 300,000 population per year. Now, children accounted for about 6% of all invasive diseases, and 21% were in the elderly. And the case fatality rate that we identified was 15%. But with STSS, whether or not they had necrotizing fasciitis, the case fatality rate rose up to almost 80%. So if you compare our series from Dennis Stevens' series, which it was obviously Stevens' study was very important in identifying this condition. But when we started to look on a population basis, it turned out that this is actually more a disease of older people who had underlying disease. And then the blood culture was almost always positive, 89%. And then necrotizing fasciitis constituted 29% of these conditions. Now, for those of you who are trainees, I want to alert you that staphylococcal toxic shock syndrome is very, very different in one unique way, that 95% of cases of staphylococcal toxic shock have a negative blood culture. And usually you identify, the presence of Staph aureus from a non-sterile site, like the rectum or some other side, the nose. So that's one big distinction, is that strep toxic shock syndrome is almost always positive cultures, whereas staph is very different. So again, you can see that, rash and, this M1 and M3 were the most common types that we had. But if you have the toxic shock syndrome, you can see that the mortality was much higher in our series, which is probably attributable to the age difference with the Dennis Stevens case series. So if we look at just necrotizing fasciitis alone, here are some of the clues that you want to think about. Usually these patients come in with a fever and flu-like symptoms. They often give a history of trauma or skin breakdown in about 40%, and they usually have excruciating pain. That's the clue. If you see a patient who comes in and they're complaining of pain that's really out of keeping with what you can find clinically, always think about necrotizing fasciitis. So streptococcal toxic shock as a as a condition is very similar. Flu-like symptoms, fever, aches, pains, and chills. If they have fasciitis, the severe pain, but in addition to that, they'll have rapid breathing and signs of pleural effusion. The laboratory findings are usually normal elevated white count or left shift, increased D dimers, prolonged INR. The albumin and calcium are typically low, and the CPK is often high, but I want to stipulate again that it does not need to be high. So one of the questions is, are children the same as adults? So first of all, when we looked in children, one of the things we identified was that the rates were highest in the first year of life. The rates were very high in the first year of life, and then it sort of tended to go down after that. And then if you compare to adults, children were less likely to have pneumonia. They were less likely to have underlying disease, which isn't surprising. They were actually less likely to have necrotizing fasciitis, with one exception, which we'll see, and that's if they had chickenpox. And they were less likely to have toxic shock, and fortunately, the mortality rate was much less, and of course, still high at 4%. But we had, of course, anecdotal reports of children who had chickenpox getting necrotizing fasciitis. And what our study here showed when we looked at the whole population of Ontario was that those patients who had necrotizing fasciitis less than 10 years of age, almost all of them had a history of chickenpox, whereas over 10 years there was not much association with chickenpox. So your relative risk for getting NF after chickenpox was 58 times compared to those who had not had chickenpox. And the actual risk was 5.3 per 100,000 cases. And one of the interesting things is that as we followed, with the introduction of the vaccine, the rates of course, varicella went down, and the rates of NF also went down with it. Just to show you that this has not gone away, this was just, excuse me, this was just in last year in the New York Post, this article where a mother was talking about her daughter who nearly died from what she called flesh-eating bacteria. And if you read the article, you'll see that it was actually group A strep related in NF, and she had to have fasciotomy. And so this was an ongoing issue. So what is the epidemiology of necrotizing fasciitis in general? So this was through the Canadian Pediatric Society, we were able to identify all the cases of NF in the whole country of Canada between the years of 2001 and 2003 using the Canadian Pediatric Surveillance System. We identified 36 total cases. 10 of them were non-group A strep related and 28 were group A strep related. 60% of them had an association with chickenpox. The mean age was 6.3 years, and the most common presenting symptom was excruciating localized pain, which was almost 100% in all the cases. So the total annual incidence was about 2.93 cases per million under the age of 16, and a little bit higher for group A strep related. And again, you can see this sort of extreme, like more cases in younger ages. There's a little bit of peak in the first year, but then it sort of goes up again between years 3 and 5. And if you look at the location, and this is a nice tip off. So those that are group A strep related, well, let me reframe it. Those that are non-group A strep related tend to be more in the lower extremity and groin and the abdomen. And then the group A strep tend to be elsewhere. So just a little tip off. Of course, it doesn't really, you always have to confirm all the cases. And again, more common in males early, and then it sort of becomes more common in females later on. This is the only reason I want to just quickly talk a bit about adult necrotizing fasciitis is just to show you the difference. So this was another study that came out of the Ontario Group A Streptococcal Study Group. And just to show you again that underlying conditions are more common in adults, which is not surprising. And chickenpox, as you can see, is a lot more common. History of chickenpox is a lot more common in adults because that's who gets, in children, because that's who gets chickenpox. Um, Adults are more likely to report a history of either penetrating or blunt trauma. The case fatality rate, fortunately for group A strep, for pure necrotizing fasciitis, because of the way they managed, nobody died in the case series that we had. Now, of course, a lot of morbidity associated. And the morbidity, of course, is fasciotomy, debridement, skin graft, or amputation. And interestingly, about 80% of the patients got IVIG. So I just show you these photos that I got in the media just to show you that survival does not mean normal, right? These are kids who've had necrotizing, or people who've had necrotizing fasciitis, and it leaves significant impairment. So if we look at a bit about the biology, of course, group A streptococci are gram-positive cocci in chains, and they really interact very closely with the human cells. They have numerous virulence factors, of which the M protein is a major virulence factor. And then the streptolysin O is one of the beta hemolytic that confers the beta hemolytic properties. Now, these exotoxins, SPEs A, C, they are known as superantigens, and I'll tell you the significance of that later on. And then you have the cell envelope proteases as well, which all allow basically group A strep to attach to cells and evade the immune system. So some of them are anti-phagocytic. So the M protein is the major virulence factor of group A strep. It has an N, which is a variable terminal, and it has a C, which is a conserved terminal. And the N terminal is really what allows us to serotype group A strep. Rebecca Lansfield described this many years ago. And if you look at the serotypes, the sequence types that are most common, M1 and M3 are most common. And then the streptococcal pyrogenic exotoxin A is often seen, but you also have others like C, and some of the strains have both. So M1 tends to have more of SPA and C. So let me just describe this idea of a superantigen to you. So you have, I don't know how visible this is. Let me go to the next slide. So when you have an immune response, you have your normal T cells, which has, and then you have an antigen presenting cell. And so the antigen presenting cell is marked, it could be a macrophage. It has an MHC receptor, and a normal antigen recognizes this MHC and this T cell receptor perfectly, and it binds in the middle here. And as a result of that binding, cytokines are released. And these cytokines are released in a very, very precise fashion. So less than 1 in a million of all your cytokines are activated, or when there's this specific immune response. A superantigen, however, binds directly on the outside of the MHC, so it's not a very specific binding, and the T cells, so that you can do this with a lot more. You can activate up to 5% of all your T cells, which leads to massive release of cytokines, which can then lead to fever, hypertension, and a lot of other issues, which is one of the challenges of the streptococcal pyrogenic exotoxins. So some of these toxins, you can see a normal antigen that would stimulate only in maybe 1 in a million of your cells. It's MHC dependent and restricted. And the superantigen stimulates a lot more of your T cells. It's also MHC dependent, but not as specific. So here's evidence in group A strep severe infection that you have a lot of cytokine activation. So we also have proteases that cleave IL-8, and I'm only going to show you this just to say that there are studies showing that a single SNP, single nucleotide polymorphism mutation, can actually alter the ability of some of these proteases to cause necrotizing fasciitis. So this is an example here where the metal transporter of streptococcal regulator with this single nucleotide change causes inactivation of SPEB, which actually reduces the ability of this particular strain to cause necrotizing fasciitis. just to make the point that there are some host susceptibility issues as well. There's some haplotypes that are less likely to develop severe disease. Now, this was an interesting story. This was a case, and actually, I've been aware of other cases where a patient in a household gets necrotizing fasciitis, and then another family member also gets this. I want to be very clear that this seems to be very, very rare. But we did actually look at this issue and found that the risk was actually elevated if you have a household member. However, the risk is still pretty low. So it seems like the longer the duration of contact, the more likely the patient have to have the household member to have also been colonized with the same strain of group A strep. So the question, of course, then comes up: should you prophylax? And you know, let me just cut to the chase. Is that right now there are no recommendations to do so, and I think you have to just sort of look at that on a case by case basis. One of the questions that also comes up is: do NSAIDs increase the risk of group A strep related NF? There have been case reports suggesting this. NSAIDs, of course, impair granulocytic function, and there's some case controls that suggest that maybe NSAIDs may increase the risk. The problem is, of course, it's hard to know because we don't know if these patients got the ibuprofen because of the severe pain, or whether the ibuprofen was given before the pain. So, it's really hard to say. However, I would avoid ibuprofen if you have any patients suspected of NF. Now, how do you treat group A strep NF? The current recommendations are to combine penicillin with clindamycin. That might seem like a strange combination, but this is really why. There's something known as the Eagle effect. And, the early studies were done by Dr. Eagle several years ago, showing that, if you took mice and you infected them with group A strep, and then you give them antibiotics several hours after initiating infection and continued for every 4 hours for a total of 4 doses, then you check the survival. The patients who received no antibiotics all died. Those who received penicillin, interestingly enough, had less survival. Erythromycin had better survival, but the best survival was with clindamycin. And the rationale that was used to explain this was, penicillins in general work better when bacteria are dividing. Obviously, they rely on division to have their impact. But by the time you get significant, massive infections with group A strep, you're actually more in a state of stability. So you've had your expansion, the cells are not dividing as quickly, so penicillin is not as active, whereas clindamycin and erythromycin do not rely on that. And of course, clindamycin, we also know, both of them also turn off toxins. So there is some evidence that having clindamycin reduces the risk of mortality. And so with adjunctive clindamycin, the in-hospital mortality rate in this study was 6.5%, and without, it's 11%. So it reduces the odds by almost 60%. So and the reason why we continue to add penicillin is because there's always a small chance that you have clindamycin resistance of your group A strep. So in terms of treatment, of course, we have to have supportive measures: fluids, electrolytes, blood products, oxygen, dopamine as needed. The most important treatment by far is surgery. So fasciotomy, full thickness. So I would actually counsel that if you really suspect this, call the surgeon at the same time as you're booking an MRI. Do not allow the MRI or the CT to delay treatment, because it could be the difference between a limb being lost or being salvaged. IVIG is an interesting story. It's certainly for streptococcal toxic shock, there seems to be some evidence suggesting that it helps. Now, a lot of the studies that have been done, there's utilization of IVIG and clindamycin. So it's very hard to separate the effect of the two. However, if I suspect STSS or NF, I tend to give IVIG. And there are some case control studies that support this. And so, usually we give 2 grams per kilo over 2 to 3 hours. And again, you can see that these seems to support giving IVIG with a better survival rate. So again, you can see here that in this particular case series, the IVIG group versus the placebo group, you can see that the primary mortality rate was less. Again, I want to highlight that there is some confounding with clindamycin. There is also some immunomodulatory impact of IVIG, which would make sense because when you do biopsies of these patients, you can see that there's incredible amount of cytokine activation. And we know that IVIG tends to modulate that. Another question that comes up with is hyperbaric oxygen. You know, technically or theoretically, hyperbaric oxygen makes sense in terms of enhancing aerobic killing of white blood cells, stimulating collagen formulation, increasing superoxide dismutase, which is obviously kills bacteria, decreases tissue edema, and down-regulates cytokines. So it makes sense. The problem is we don't have a lot of experience with it. And there are some risks, in children: tympanic membrane rupture, CNS toxicity, risks of transportation, fire, and costs. So right now, we're not recommending this. Now, obviously, this can be a case by case. You have to weigh the risk versus the benefit if a patient is really sick. A little word on vaccines. Vaccines can either be based on the M protein or the polysaccharide capsule. The big challenge with the M protein is that it cross-reacts with a lot of human tissues, which is why we have a lot of the post-streptococcal non-infectious sequelae, like myocarditis and glomerulonephritis. And basically, there are two approaches to using an M protein vaccine: is to use the non-cross-reactive epitopes of C-repeating regions in the constant region of the M protein, or to take the N terminus and fuse it to polypeptides of polysaccharide vaccines. So these vaccines are generally well tolerated, they're highly immunogenic, and they evoke opsonic antibodies against vaccine-specific serotypes of group A strep without cross-reactive antibodies if you pick the haplotype fairly carefully. There are now 3 studies at least of multivalent group A strep vaccines. Because of time, I'm not going to be able to dive into them much, but just to say that there's now at least a 30-valent vaccine that's based on M protein conjugated with the different capsular types. And it seems to, at least in this particular strain, in this phase 1 study, to have some opportunity for success. There are a lot of other vaccines in development that use, based on antigens, different types of antigens, to different parts of group A strep. And so, in summary, invasive group A strep have increased actually recently as a cause of morbidity and mortality in children and adults. I want to just frame this by saying that this is something that we see over years. So some years you're going to see waves of group A strep. In the last couple of years, there seems to have been an increase. And then perhaps as immunity wanes, as immunity goes up, the rates go down. And then as immunity wanes, it comes up again. NF and STSs are relatively rare in children, but they do occur, and it's important to have a high index of suspicion. The respiratory, skin, and soft tissue are formed on foci. And fortunately, because of the vaccine, we shouldn't see too many cases associated with chickenpox, but we do still see occasional ones. Early diagnosis requires an awareness of the presenting features and a high index of suspicion. Fortunately, it's not a major risk for death in children, but it's got significant morbidity. I would avoid using NSAIDs in patients with NF, and the mainstay is surgery, and then antibiotics, IVIG, and then hopefully in the future vaccines. I just want to acknowledge that a lot of the work I presented here was done by an extraordinary team of researchers from Toronto. Alison Mugere, who is a distinguished professor there, Don Lowe, who unfortunately has passed away, Kevin Lopland is now a professor in Australia, and a whole team of people over the years, and the Canadian public health system there. So I'm going to stop there and see if anybody has any questions.
Thank you, Dr. Davis, for that fascinating presentation on group A strep infections. Let's see if anybody has any questions or comments. So what would be the indications for the vaccine you talked about, the group A strep vaccine? Who should get them?
That's a great question. Well, group A strep infections are really very common, as you know. Of course, invasive infections are not the most common presentations, but of course, you have cellulitis, right? We have impetigo. We have a lot of other skin conditions that are associated with group A strep. And of course, it also causes conditions like pneumonia and, of course, invasive disease that are not necessarily severe. And so part of what we need to do is add up the cost of all those infections and determine, is this a vaccine that all children should get? I mean, obviously, it'll depend on the cost of the vaccine and also the efficacy of the vaccine in terms of making that determination. So it's a great question. We don't actually, I think there'll actually have to be some significant thought as to who is best. Most likely, my guess is that you probably want to start with a group of people who are at increased risk, and then maybe map it out to the general pediatric population.
Thank you. There's a question in the chat box. I may have missed this, but why is varicella such a huge risk factor for NF?
Why is what? Sorry.
For necrotizing fasciitis.
Why is
varicella such a huge risk factor?
Yeah, the most likely reason is that the skin's broken down, and group A strep colonizes the skin, and then just allows the bacteria to get in. So it's the most likely reason.
There's another question: methylene blue effect on infectious diseases. What is the mechanism?
Methylene blue. Methylene blue. You know what? I believe it's a superoxide. I need to double check that though. I don't want to give somebody the wrong information.
Any other questions, comments? Yeah, we used to use methylene blue in India when I was in training for umbilical cord prevention of umbilical cord infection. Very common, and I remember our hands used to get blue, the clothes used to get blue because we used to apply it to the umbilical cord.
Yeah, I've used it too. In India, actually, I've used it.
Any other questions, comments for Dr. Davis?
Are there any other questions, period, about infectious diseases?
I don't see any comments or any hand. Thank you very much, Dr. Davis, for educating us on group A strep infections and management. Truly appreciate it. I know you're very busy with your new responsibilities, so thank you. I appreciate it. I'm going to conclude this morning's grand round. Thank you all for attending. We'll see you next Friday at same time. Have a wonderful weekend. Thank you.
Thank you very much. It's a pleasure talking to you all.